Hey everyone, we are back here with another video for our medical student clerkship preparation series. And today we're going to talk about the abdominal exam. We chose this as a topic both because we think it's well suited to the format we've been using to make these videos, but also because this is really a foundational skill of medicine. Whether you go into surgery or not, just about every physician will need to have good familiarity and skills with the abdominal exam. So we really wanted to go back to first principles and talk about what the underlying causes of abdominal pain are and give you a formula to more systematically and accurately understand abdominal pain when you see a patient, maybe for the first time in the ER or as a consult, something like that. And the reason we want to do this is we're always trying to translate that all that knowledge that you've built up over the first and second years of medical school and then put it into a vessel that's more clinically useful. So instead of reading a UWorld stem and getting all the data right off the bat and trying to pick the perfect one disease from a constellation of symptoms, I found that it's much better to think about these things systematically and really understand where and how abdominal pain presents, and then use that to guide your questions and physical exam as you try to make a diagnosis instead of only trying to rely on that pattern recognition where people don't read the textbook. So a lot of times you need to be thinking a little bit outside the box and be allowing the data in front of you to guide your decision instead of always trying to just hope you happen to get that classic textbook presentation. So there's really two key points that allow us to start thinking about and subdividing abdominal pain, and that's visceral pain and somatic pain. And if you were able to get a good understanding of this from your medical school, I salute you. You had a better school than mine. So sorry if this is rudimentary for some of you. But visceral pain is really just talking about pain that comes from the organs themselves. So not the skin, not the abdominal wall, but the actual organs inside of your abdomen. Your stomach, liver, gallbladder, appendix, maybe colon, all those organs that are commonly involved in causing pain. Those have nerve fibers that go to these ganglia and then get spread across several different dermatome levels, and that's why they give us this more vague, crampy pain. If you think about it, your organs actually don't feel much pain. We can go into your belly and cut your colon in half, sew it back together, and then you won't feel that when you wake up post-operatively. They don't feel cutting, they don't feel stabbing. All they really feel is distension. So think about them swelling as they get full of something or trying to push past an obstruction, or chemical irritation. So those are really the only two causes of this visceral pain, which once again presents more dull, sometimes crampy, and does not localize well. Where somatic pain, on the other hand, this is really pain associated with the abdominal wall. And since we're talking about the abdominal cavity, what we really mean by that is the parietal peritoneum, or that peritoneal layer that lies on the inside of your abdominal wall and kind of is slick, and organs touch it and brush against it sometimes, but it's not like it's actually coming from an organ. Pain that we call somatic pain comes from an organ, usually an inflamed organ, or some sort of chemical irritant, such as air or blood or succus, touching that inner lining of the abdomen. And this pain is very different from visceral pain. So if you know these two distinctions, you can right off the bat from just a history start narrowing your differential. So the somatic pain is sharp pain. It's very focal pain. They can point to just this one spot. It's right here. And those are some key differentiators from visceral pain. And a key thing to remember is that most abdominal pain starts visceral and then progresses to somatic. So this was a nice illustration that I found online that kind of highlights what I was just talking about in the last slide. So you see here these, I guess, pink fibers. These are supposed to be your efferent fibers. They're coming from your various organs, coalescing into these ganglia. And then you see they actually spread out from these ganglia to go to multiple different dermatomes. So it makes sense that, let's say you're having pain in your liver or something like that, you would feel this more vague pain crossing several dermatomes in one part of your abdomen. You wouldn't really be able to tell me exactly where that was coming from. Same with your appendix down here. It comes to this ganglia, then spreads out. So typically when your appendix starts to hurt, that's why you have this pain around your belly button across a couple dermatomes. It's not until the somatic pain comes that it really starts to localize. So now over here, we're looking more, this is supposed to represent the parietal layer. So you can imagine if maybe this part of the peritoneum is the part overlaying your appendix, that's going to irritate this nerve and come directly to a single dermatome and be much more focal. And then it's also going to feel sharp as well. And so I want to talk about a term quick, peritonitis. This term means exactly what it's spelled like. So periton for peritoneum, or that that parietal layer of peritoneum on the inside of your abdominal wall. And then itis means inflammation. So typically if somebody has peritonitis, we're usually referring to diffuse peritonitis, which means inflammation affecting all your peritoneum throughout your entire abdominal cavity. And that is a very severe issue, usually a sign of a surgical emergency, because that usually means there's a bunch of blood or a bunch of succus or maybe a bunch of free air in the abdomen that's causing pain all over. You can't really localize it. And so that's why this term peritonitis often gets, our hairs to stand up. It almost always signals surgical emergency. But if you think about the definition of peritonitis, that all it is inflammation of that parietal layer, then you realize that actually peritonitis happens in a lot of different abdominal pathologies. For example, when you start to have that somatic pain of appendicitis, that is actually peritonitis as well, right? Because it's caused by that inflamed appendix that is touching either the anterior, in which case you just have right lower quadrant pain, or posterior parietal peritoneum. In that case, you'd have more of like a psoas sign or some atypical pain with your appendicitis. But either way, that's causing inflammation of the peritoneum, but it's only causing it in a local area. So somebody could have a physical exam that implies peritonitis, right? And what that is typically is things like rebound tenderness. Some people will do the test where they push in and let go and ask if there's more pain when they press or release. And if there's more when they release, they would call that peritonitis. You can also do things like kicking the bed. In that case, that more tests for a generalized peritonitis. But either way, you can have peritonitis focally, and usually focally is not that four-alarm major surgical emergency that we think about when we think of diffuse peritonitis, and it's frequently what you'll hear tossed around. If somebody goes to see a consult in the ER, maybe they walk back and say, oh, that patient has peritonitis, and they start mobilizing the OR and things like that. Those are trying to clear up some words that we frequently use interchangeably there. So actually, I want to go back for a moment and just talk again about an example of how this might present in real life. So let's say that somebody's developing an appendicitis. So their appendix sits somewhere down here in the right lower quadrant. It's a very large appendix. And if you remember the pathology of appendicitis, there's usually a fecalith or a stone somewhere at the base, and that causes this back pressure back here. Anytime you block off a blind tube, you get an infection. So you get increasing pressure and increasing infection behind there. Your appendix dilates and dilates, and that's starting to cause that visceral pain that we talked about. So remember, visceral pain, all it senses is either chemical irritation or more commonly distension, right? So in this case, your appendix is distending and you're activating those vague fibers that are hitting several different dermatomes. So usually you're going to be getting this vague periumbilical pain. And then eventually the inflammation of your appendix progresses. Now you have this big, angry, dilated appendix with full thickness inflammation. And this appendix runs into the parietal peritoneum on the inside of your anterior abdominal wall. Bam. Now you have peritonitis and inflammation, and you have that somatic pain. It's sharp and it's right here. So that's that migration of this vague visceral pain for your umbilicus down into that somatic pain of your right lower quadrant. And if you think about this, this applies to most other abdominal pathologies as well. Think about your gallbladder, biliary colic. Once again, stone in the neck, back up, you get this pressure, you get this distension, and that causes that visceral pain. And then if it gets bad enough, you get full thickness inflammation through that wall. That whole wall is inflamed. You have cholecystitis, Then that inflamed wall touches the anterior abdominal wall, hits that parietal peritoneum. Boom. Oh, I had this nausea, this pain in my epigastrium that's not well localized. And now all of a sudden I have pain right here, right in the right upper quadrant. That's probably your gallbladder progressing to somatic pain. And once again, denoting that classic progression of visceral to somatic abdominal pain. All right, so where was I? Oh, yeah. So I wanted to then give a few examples so we can just say, you see a patient in the ER, first thing you do is talk to them. So let's do a quick quiz together. What do we think? What type of pain do we think each patient example here is having? So a patient says, oh, I've got this pain. It comes and goes, which of course we know means colicky. It's crampy. It comes in waves. So this pain, I didn't write it here, but is usually more vague. And this sounds a lot like a bowel obstruction, right? So it comes and goes. Usually that's with the peristalsis of the bowel, where it's distended and it's trying to push against that substruction, and that causes some crampy pain. And then the bowel stops flexing and goes away. Same thing with biliary colic, and potentially even the same thing with early appendicitis. But definitely a visceral pain, definitely not a somatic pain. The next example, worst pain in my life, started at 4:02 p.m. So if they know exactly when that pain started, there's nothing vague about that. We're immediately thinking about peritonitis. And the worst pain in my life, this is the classic story for something like a perforated gastric ulcer, where boom, 4:02 p.m., the stomach opened up, fluid gushed everywhere, and now they've got chemical irritants sitting all over their organs and contacting their parietal peritoneum, and they are just having terrible peritonitis and pain and the surgical emergency. And this last one is a sharp pain, and it's constant, and it's right here. And they can usually point with one finger at the spot. That's a good question to ask people. Point with one finger at the pain. And that pain, of course, is well localized, and it is constant. So that's probably inflammation as opposed to intermittent flexing and distension against obstruction. So that is going to be a somatic pain. And how about what the patient will do, right? So you go in, you look at them. What's your general exam? We have a patient sitting stock still. They won't move a muscle. They're sweating. They're in extremis. So this is the classic patient with generalized peritonitis. Their whole abdomen is in terrible pain. They're sweating. They're probably tachycardic and really sick. And they're sitting stock still because they have a bunch of fluid in that abdomen that's irritating the peritoneum. Excuse me. And every time they move, they feel just worse, terrible pain. So they try to not move at all. Now, somebody writhing, trying to get comfortable, that sounds more like a visceral pain. So they don't have some fluid irritating their peritoneum, because if they moved around and they had that, it would hurt a lot worse. In this case, they just hurt. They're trying to move, trying to get comfortable, but they clearly don't have a perforation. Now, this can still be very serious. If they're in just tons of pain, this could be your ischemic pain from something like an ischemic colitis or mesenteric ischemia. But regardless, this is not classic peritonitis. And the patient could be sitting comfortably. And if that's the case, they might be having visceral pain where it just comes and goes, that colicky pain, or they could have somatic pain that's really not too bad at that moment. And so that's when you've got to, once again, ask them some questions and figure out what's going on, do your exam. And then to finish up, we're just going to go through how I would do a step-by-step abdominal exam. So step one, you always want to look at the abdomen. Always ask them to lift up their hospital gown. You can get a lot of information. For example, you don't want to be somebody who just pushes on the belly and says, oh yeah, they have appendicitis. And if you'd only looked under the gown, they actually had shingles that was in that quadrant. The other data that's really important that you can get from that is you can see if they have a bunch of surgical scars, and you make sure to really get a good surgical history on that patient. I crossed out listen here because we really don't listen very much anymore. It used to be the classic, listen to see if it's ileus or a small bowel obstruction, but there's been many studies that the sensitivity and specificity of listening is not very good, and realistically, we don't do it very much as residents. The only time I will listen to somebody is if I'm suspecting they're not giving me good data when I'm pressing on their belly. Maybe they're overreacting, and I want to press a little bit without them realizing I'm pressing. Then I move right to percussion. I like to do this in all four quadrants, and this is really my personal test for peritonitis. I don't like the whole push and release game. That, I think, confuses patients. So what I'll do is I'll just gently tap, acting like I'm listening, which I'm still listening and getting some data. But really what I'm trying to do is if I percuss and that causes that wave that shifts their abdominal wall, really, and what I'm looking for is that quick shift of the parietal peritoneum. If that causes them terrible pain, then they have peritonitis, either right where I'm tapping, or if I go all four quadrants, they have that pain all over the place. They probably have generalized peritonitis. I'm getting really concerned. And then after the percussion, unless it gives me all my data, and it would just be cruel, right? I don't want to just go pressing all over somebody with bad generalized peritonitis. But then I start with palpation. So if somebody has right lower quadrant pain, I'll make sure to start away from the pain and then start with light and move to deep palpation and just get a sense of if they have any tenderness or somatic pain that wasn't severe enough to cause peritonitis. And then the last thing you can do is some maneuvers, which are going to depend, of course, on what pathology you think is going on, which is another reason why it's good to be able to formulate your differential right off the bat with just your history, because you know which things to test. You don't have to get your CT scan first. And I debated not adding the slide here at EduRafi. We're really about learning major concepts, not about memorizing trivia, but I thought I'd throw some trivia in here just in case anyone was interested, of commonly pimped eponyms for physical exam signs. So Murphy sign, that's for the gallbladder. That's when you push in the right upper quadrant. Well, you don't push, you just hold your fingers in the right upper quadrant right below the right costal margin. Have them take a deep inhale while you slowly press in. And if they stop inhaling because of the pain, that's Murphy sign. McBurney sign is pain in the right lower quadrant, essentially 2/3 of the way between the ASIS and the umbilicus, and that's classic for appendicitis. Psoas sign is also appendicitis. How I do that is I have the patient lift their right leg off the bed while I push on their knee. If that causes irritation, their appendix is probably posterior, and pushing against or irritating the posterior parietal peritoneum back there. And then Rosving signs, when you press on the left lower quadrant and they have pain in the right lower quadrant, which again just signifies an inflamed appendix. And then finally, the Hauschip-Romberg sign, that's when you have an obturator hernia or you're suspicious of one. And that's really just pain with internal rotation of the hip. So you can either just log roll the hip or you can lift the knee up off the bed and rotate the calf, or the leg, I should say, relative to the knee, side to side, which will get your internal external rotation and see if they have severe pain. But once again, this is really just meant to be a review of the abdominal physical exam. Hopefully you learned something useful. Hopefully you are comfortable that you have a system where you can really think your way through abdominal pain as it presents to you and do a smart, systematic workup from there. Let us know if you have any questions. This is not meant to diagnose or treat any disease. This video is for educational purposes only. We will see you next time. Thanks. Bye.